they say if you stay someplace long enough, you end up looking like your surroundings. So here, just assimilating a little bit, I'm happy to present to you some cases from the Pediatric Emergency Department. Now, I've done my cases a little bit differently than the rest in that I'm going to go through, give you the case and then the questions, and then we'll go through all the possibilities and then come back to the answer. So we'll go through it all. And I have one in the beginning. But first, the objectives are to review several common and a few unusual pediatric emergency presentations and to discuss the differential diagnoses and highlight some important findings. So we're going to just start with a dummy one. You don't have to answer this one if you don't want. So this is the current status of a ski hill in Ontario. This was taken yesterday, and you can see that there's a slight problem there. So why is the ski hill empty is the question. Is it too cold outside? By now, the ski equipment has been lost. Just the lift lines are too long, or Canadians have had enough of winter. So this was the temperature yesterday, minus 14, feeling like minus 21, so I am a little sad to go back, quite frankly. Nope, they found the gear. That's no problem. So these are my two sons. As you can see, there are absolutely no people there. The lift wait time is 30 seconds. The problem is that Canadians have gone clearly crazy in the snow, and most Canadians are officially done with winter. It is spring after all. So let's go for the real case. It's a 17-day-old neonate, palpable deformity of the scalp. It's not regressing. The parents are quite anxious. It's firm, and there was a prolonged delivery. So you can see here that there is a soft tissue mass of the scalp. It doesn't cross the sutural line as indicated by the blue arrow. There's soft tissue periosteal elevation, no associated skull fracture, and a sharply demarcated soft tissue density in the parietal region. We did some ultrasound of the area, and you can see a mirror image artifact that can be confusing regarding the underlying brain and possible epidural process. This is a later presentation of the same diagnosis, and the outer border may calcify as a rim. So, again, here on ultrasound, you can see continuity of the outer periosteum with peripheral calcification as indicated by the yellow arrow. It's important to see that the calcification continues along and that there's no true internal vascularity. So what's your differential diagnosis? You have to pick one. Is it caput succedaneum, subgaleal hemorrhage, cephalohematoma, or a soft tissue tumor that we don't quite know about yet? So please make your choice. Now you can make your choice. So caput, subgaleal hemorrhage, cephalohematoma, or soft tissue tumor. Excellent. Okay, good job. So we'll go through each of these, and we'll see how you did. So caput succedaneum is something that we actually don't image very often. It's subcutaneous hemorrhage. It doesn't require any intervention, and it's usually the reason little babies wear toques, even if it's hot outside. So it occurs immediately after vaginal delivery. Again, we don't image it. It's not limited by suture lines as it is in the soft tissues. It can be associated with discoloration and bruising, and it heals spontaneously. Subgaleal hemorrhage, on the other hand, is bleeding into the subaponeurotic space from rupture of emissary veins, and this does cross suture lines, covers a larger area, typically compared to cephalohematoma, and it is potentially life-threatening, and this is associated with vacuum-assisted delivery and trauma. So here you see subgaleal hemorrhage on an x-ray. It looks quite similar to our current case, but there's an important finding here on this x-ray where you can see that there is an associated fracture and as well an epidural hematoma. So subgaleal hemorrhage. So cephalohematoma is what we're going to talk about next. It's soft tissue periosteal elevation with no skull fracture, sharply demarcated soft tissue density, does not cross suture line, and has continuity of the outer periosteum with peripheral calcification, and the outer border may calcify. This may take months to regress. And soft tissue tumor. So soft tissue tumors, many are prenatally diagnosed. They can be variable on presentation depending on the tumor type. In this case, you can see phleboliths, hemangiomas, in this case with fibroids or vascular tumors. So the diagnosis in this case is cephalohematoma. So good job. Okay, just to, in between, this is the atrium of our hospital at Sick Kids. It's changed a little bit. There were dancing cows that were on a trolley, but they were deemed a risk, so they were removed. So dancing cows are bad. That's the take-home message. Okay, next case, 3-month-old with torticollis. And age is important here. Palpable mass in the neck, noticed shortly after birth, and gradual increase in size with no skin discoloration. So ultrasound of the right neck shows a subcutaneous echogenic mass that's heterogeneous with no calcification. And you can see the yellow arrow is indicating the fibers of this sternocleidomastoid muscle. It's well defined and it's lobulated. Again, you can see further images of the sternocleidomastoid muscle overlying that has a thinned and oval shape, and the blue arrow denoting part of the mass. There is some internal vascularity, but no large tangle component to this, and the echogenicity looks similar to the subcutaneous fat. In this case, T1 weighted MR we have here. It's not fat suppressed. You can see defined lobulated subcutaneous lesion with no phloeboids, fatty tissue within, and heterogeneous intermediate signal with some septation. With fat sat, you can see saturation of the lesion there. And with gadolinium enhancement, there is really no enhancement of the fatty components, but the periphery and septations enhance. So given this information, the differential diagnosis is this subcutaneous fat necrosis, lipoblastoma, fibromatosis coli, or infantile fibrosarcoma. Please make your choice. Hoping for 100 here, hoping. Pretty good, okay. So subcutaneous fat necrosis is something that usually has a history of a difficult delivery, and it's a firm, palpable area, usually appearing days to weeks after birth. It can have increased vascularity. It has an inflammatory component to it. Usually has well-defined margins, and they're lobulated and hypoechoic. On the skin surface, there's usually some element of plaque associated with it, and the issue is that you need to recognize it can be complicated by hypercalcemia, nephrocalcinosis, and nephrolithiasis. And what does it look like? Well, you can see in the upper panel there, where we have more of a panoramic view, there's echogenic lobulated subcutaneous fat that looks quite unusual. And this is the normal contralateral side, where you can see normal flowing fat that is of normal echogenicity. Again, in the posterior neck here, the lobulated echogenic fat. A little bit hypervascular. Normally, the subcutaneous fatty tissues aren't terribly vascular. Next is lipoblastoma. This is typically subcutaneous, again, well-defined, seen almost exclusively in children under 3 years of age. Can be seen very close to birth. The difficulty is it can be indistinguishable from a lipoma or liposarcoma. So once you identify that there's true fatty tissue in it, you just have to look at the age of the patient, and most of these go on to excision anyway, so the pathologist can deal with the rest. But it has variable soft tissue and mature fat. So the trick is to just identify that there is mature fat within that. Immature and fibrous components enhance. Those are the ones that enhance, but the macroscopic fat does not. Again, so this is the index case you can see, and this is a classic appearance of lipoblastoma. Fibromatosis coli is something, though, that is very common, and it's important that the history fits the imaging so that you don't mistake it for something else. It's, again, a benign manifestation of infantile fibromatosis. Dr. Schroff talked about this yesterday in his head and neck imaging. Mass-like fusiform enlargement of the sternocleidomastoid muscle, and the thing is that you want to identify the fibrils, the muscle fibrils, continuous through this lesion. Even though there may be some fibrous change, they should be continuous. Frequently is associated with shoulder dystocia or difficult birth, and proximal and distal muscle fibers extend. It can be mildly hypervascular, but I'll show you another lesion that differentiates it. And no calcifications or cystic areas are typically found with fibromatosis coli. And here you have the classic appearance. It's a spindle-shaped lesion. Important to note again that you can see, at least in some parts, continuation of the muscle fibrils through, identifiable on ultrasound, and it's not terribly hypervascular, some internal vascularity. And that's contrasted with infantile fibrosarcoma, and we've had several cases of infantile fibrosarcoma. This is a solitary, rapidly enlarging firm mass. What's interesting in this case is that it doesn't have the same timing as fibromatosis. So if you end up with torticollis in an older child that's distinct from the birth history, then you should worry about that, and that's what happened in this case. Fibrosarcoma at all can involve areas of hemorrhage or necrosis. Certainly it's not specific to the sternocleidomastoid muscle. It's vascular, has larger feeding vessels at times, and it disrupts the muscles. So that's the characteristic that you're looking for, although it can have well-defined margins. And here you can see the differences between the Fibromatosis coli and infantile fibrosarcoma in that the vascularity is significantly more, that you have a somewhat defined lesion within it, within the muscle, expanding it, although it does overall maintain a fusiform shape. But the fibers are disrupted, so that's the important take-home message to distinguish these. The infantile fibrosarcoma, again, relatively homogeneous mass, avidly enhances post-gadolinium, and these are characteristic images pre- and post-gadolinium. So in our case, the diagnosis is not fibromatosis coli. It's actually lipoblastoma. Okay, sorry about that. This is the registration and waiting area, and one of the things that, from the pediatric perspective that we have in our hospital is that we really try and make areas friendly for kids and parents. There's a lot of anxiety that goes on, and it's just to show you don't have to have necessarily children's tables, but even something interesting on the wall can help calm some anxiety and make a friendly space. Next case, 18-month-old, 1 month of neck pain, decreased range of motion, no trauma, head tilt, and no fever. So this is the x-ray here, and you can see that there's flattening of the C4 vertebral body. Again, permeative appearance to the bone, displacement of C3-4 at the spinal laminar line. So certainly from Dr. Shroff's talk, we should all be knowing where to look now. So you can see, look at your spinal laminar line, reversal of the physiologic lordosis, and prominent anterior soft tissues. So imaging in children of the neck is always somewhat difficult because of pseudosubluxation and lacks pharyngeal tissues, but in this case, there's a defined abnormality of the bone. CT scan was done, and you can see that there's a destructive lesion involving C4 with vertebra plana, permeative appearance, and some soft tissue component anteriorly with some indentation of the thecal sac, so you can appreciate in this soft tissue window. MRI shows an expansile exophytic soft tissue lesion involving the right lateral process, and it's displacing the right vertebral artery. So the differential diagnosis, which would you pick? Is it metastatic disease, Langerhans cell histiocytosis, otherwise known as EG, fracture, or osteomyelitis? Please make your choice. Excellent. Very good. Okay. Either you know a lot or we've taught you something. So metastatic, both are good. Both good. So metastatic disease in pediatric population, neuroblastoma mets was probably the most common metastatic skeletal disease that we see, as well as leukemic involvement. And there are some other childhood primary lesions that can have invasion and skeletal involvement, such as clear cell sarcoma. Sclerotic margins are not usually a feature of metastatic disease, and the degree of collapse is variable. It may or may not involve the whole body, and you can have a lesion with adjacent invasion. So here in this child, you can see a large tumor with an adjacent involvement of a pedicle, part of a pedicle in this case, with some relative vertebra plana, and that and this is a demonstration of neuroblastoma with adjacent invasion of the vertebral body. Langerhans cell histiocytosis, we talked about this yesterday. We talked about it with regards to the chest and cystic lesions. But in the bones, there are lytic lesions with geographic margins. There may be multiple. These are not typically found on bone scan because they're cold, so skeletal surveys are typically undertaken for them. Again, it's difficult to see something that's not there, so cold lesions on bone scan are quite difficult. Again, as you can see in this case, skull lesions, there are multiple here. That's not terribly specific appearing, but you can see multiple lesions. We're taught about the beveled edges of the skull lesions, but they don't always read the books. Again, look elsewhere here. You can see lots of lesions with endosteal scalloping and vertebraplanar or partial compression at multiple levels. So the differential diagnosis of vertebraplanar is something just to go over. Certainly fracture, E.G. or Langerhans, tumor, infection, steroid use, and hemangioma. Whenever you see vertebraplanar, those are things that should come to mind. So in this case, the diagnosis was Langerhans cell histiocytosis. Again, this is our CT department. Not too many CT suites have a disco ball in them, but hey, we like to have fun at work, and I think the people at KOC do too, because they're very close family, so congratulations for that. Next case, 5-year-old boy, right flank pain and fever, and possible renal mass on outside ultrasound. And some of these images should look similar to ones I've shown you before because they are the same. And my hope is that you've learned something from this case. So you can see here that there's normal upper pole parenchyma because with normal corticomedullary differentiation, and a mid-pole renal lesion that appears relatively hypovascular. There is ill-defined echogenic with relative reduced perfusion compared to the remainder of the kidney with some mass effect. No cystic region or calcification, and in this case we don't see any perirenal fluid. Differential diagnosis is this: acute pyonephrosis, mesoblastic nephroma, renal abscess, or focal pyelonephritis. So please make your choice. Sue. Okay, now you can. Aiming for 100 here, aiming. Okay, I'll take that. So, acute pyonephrosis is infected obstructed urinary tract, pyo meaning pus, nephrosis being kidney. So this can be due to UPJ obstruction, stone, or potential bladder outlet obstruction in children. Posterior urethral valves is a common cause. Acute pyonephrosis is something that requires decompression, so it would be something that may require nephrostomy, either that or alleviating the obstruction. In children with posterior urethral valves, again, catheterization and fulgurization of the valves at some point. So this is an appearance of acute pyonephrosis, and you can see that there's layering debris and dilatation within the distended calyces, some relative hyperemia of the parenchyma. We can see a little bit of perinephric fluid around the kidney, and again, this debris within the collecting system. Mesoblastic nephroma, again, this is a tumor that frequently presents in the neonatal period, usually less than 3 months of age, but almost always less than a year. Mimics Wilms tumor, no malignant potential, and it's a large non-tender mass of presentation, but they can bleed, so they can look unusual as well. And they can have somewhat ill-defined margins if they have been complicated by bleeding or necrosis. So again, this is the appearance of mesoblastic nephroma, normal upper pole here with good corticomedullary differentiation and normal vascularity. And in the lower pole of the kidney, as indicated here, you can see a striated almost appearance to the lower parenchyma with abnormal whirling of the flow to the kidney and reduced flow overall. And this was shown on MRI. You can see the lesion. Relatively bland appearance in the lower pole here with limited enhancement post-gadolinium. This was a child with mesoblastic nephroma. Renal abscess, well, what do those look like? Well, typically they're a well-defined area because they've had chance to organize and subsequently cavitate or necrose. They progress from focal pyelonephritis and they may or may not have perinephric fluid. Most often in the population that we image in pediatrics, these are children that are either immune suppressed or have sickle cell disease. So again, here, early abscess formation, you can see this lesion that looks somewhat ill-defined. You can make out the margins here. It's always better when it's got the calipers on it because then it looks like a real lesion. You can see that there's some necrosis centrally within it, and it's relatively avascular. Over time, despite the fact that this patient was treated, it went on to further necrosis with cavitation and liquefaction centrally for renal abscess. Focal pyelonephritis is something that both Dr. Hanbinch and I talked about yesterday. It's a pseudomass, and it's something that's really important to recognize because calling a lesion that is treatable and is ultimately a relatively non-aggressive lesion a tumor causes all kinds of havoc. I mean, you absolutely want to do the right thing by the patient, but again, in recognizing what it looks like, hopefully we'll be better in our diagnostic acumen. Focal pyelonephritis has no cystic change within the region, and even though there is limited vascularity to the area involved, the kidney overall typically undergoes some element of swelling, and the size discrepancy can be larger than a centimeter. Focal area, again, relatively reduced perfusion, and this can lead to scarring on follow-up DMSA studies. Again, the lesion that I showed you, and so in this case, the diagnosis is focal pyelonephritis. Fluoro room, I spend a lot of time here as I am the lead for GIGU, so it's nice to have some fish and be close to the sea. Case 5, rapid onset scrotal swelling, very painful to touch, reddish discoloration, bilateral and afebrile. So here's two images, transverse images across the midline of the scrotum. You can see this fountain-like striated appearance of edema and hypervascularity, marked homogeneous thickening of the scrotal wall. You can see that the depth here is indicated by centimeters and is over 2 centimeters deep, and you still haven't been able to see a testicle yet. So marked homogeneous thickening, and when you do get to visualize the testicles, they're have relatively symmetric perfusion bilaterally and normal homogeneous echogenicity. The differential diagnosis here, this is again a spot diagnosis. If you've seen it once, you know exactly what it is, and if you haven't, hopefully we'll take away something today. So is it acute idiopathic scrotal edema, Henoch-Schonlein Purpura, leukemic infiltration, or appendix testis torsion? Please make your choice. Still aiming for 100. Come on, come on. It's like the Wheel of Fortune, right? Okay. So, acute idiopathic scrotal edema. It's something that once you've seen it, you'll never forget it and you'll never get it wrong. And it's erythema and swelling of the scrotum, usually bilateral. It can be slightly asymmetric, and it's much more common in children than adults. I don't know why. But ultrasound is diagnostic, and it's been something that was written up by colleagues at our institution who are now in practice in the U.S. It's increased blood flow in the scrotal soft tissues, and it's got the characteristic fountain sign, and it's not associated with dysuria, and it's completely separate from the testicles. And this is what it looks like. It just, everyone I've seen, all of them, they all look the same. It has the classic fountain sign, and the idea is that centrally, you have the spout, and then the fountain kind of goes out from there, from the median raphe. Henoch-Schonlein Purpura is something that is fairly common in children. It's acute systemic vasculitis, frequently involving the skin, and it too can present with an acute scrotum. It's something that in some of our patients we end up doing ultrasounds for because it's difficult to decide whether or not it's actually a scrotal problem or a testicular problem or some other problem. Blood supply to the testis is normal, but it's abnormal to the skin, and you have some ecchymosis of the skin. The difficulty is that the purpuric lesions that you expect to see in Henoch-Schonlein Purpura don't always manifest at the time that the skin swelling is seen, so that they may come in alternate order. Once the purpura is there, it's pretty easy to make the diagnosis. And this is what Henoch-Schonlein Purpura looks like. And you can see that in this case as well, there's marked swelling of the scrotum. The testicles are okay. And again, you can see this very, really thick but organized appearance of the scrotal skin. Again, the underlying testicles are normal. Leukemic infiltration of the testes, what does that look like? Again, this is an important diagnosis to be able to make because in children who have had either previous history of leukemia and been treated or shielded or are worried about recurrence, this is a diagnosis that's also fairly classic in appearance. You have enlarged hypoechoic testicles or just one testicle. Is asymmetric and it may be heterogeneous in echotexture, but it may be very similar in echotexture. Scrotum may be slightly red, but typically not thickened, and the testicle is hypervascular on Doppler. And again, you would expect a history of leukemia, or they would end up with a history of leukemia. You can see here this marked asymmetry between the two testicles. The left testicle is almost double the size of the right testicle. And importantly, the vascularity is markedly different. So here in this midline scrotum appearance, you can see that the left side is quite large and really hypervascular. So that's leukemic infiltration of the testis. If you look at the echogenicity of the parenchyma here, though, they're almost identical. So if you're looking at one testicle, make sure you look at both. So torsion of the appendix testis is something that we also went over yesterday. Again, torsion of any of the appendices, whether it's testis or epididymis. You look for an avascular mass. They can mostly hypoechoic, but can be mixed, are usually associated with reactive hyperemia or hydrocele. And the importance is that they're self-limiting and usually unilateral. I've never seen bilateral process happening at the same time. In this case, this is a similar image that I showed you before with the rounded avascular lesion in between the epididymis and the testis here, and a normal appearing testis. So the diagnosis here is acute idiopathic scrotal edema. So if you haven't seen it before, congratulations. Now you'll never mistake it for anything else. So again, our other fluoroscopy suite and nuclear medicine, we have some art on the walls, some more than others, but just to try and lighten things up. Case 6, so we're getting there. Fall on outstretched hand and elbow pain with limited range of motion and the request to assess for fracture. I find it kind of funny what we get for our referrals, quite honestly, because you'll have this obvious deformity with the bone sticking out, and they'll be like, query fracture. Really? Okay, maybe you should examine the patient. Anyway, so in this case, we have an x-ray, actually several x-rays, and you can see here that there is a lucency posteriorly. We see a posterior fat pad, an anterior fat pad, and you can see, again, a little cleavage plane. So just have a good look around the elbow, because you're going to need to review your elbow imaging in children. So how does ossification happen around the elbow? Everyone has crito or critol, and that's the order of presentation of the ossification centers. And every time I look at an elbow in a child, non-fused skeleton, I always go through this. It's like every chest x-ray, I count all the ribs. Every elbow x-ray, I go through crito. So capitellum, radius internal or medial epicondyle trochlea, and having a fragmented trochlea appearance is something to consider, and lateral epicondyle, so critol or crito. Differential diagnosis here based on the image, which I'm just going to show you one more time. Is it a medial epicondyle avulsion, a supracondylar fracture, a Monteggia fracture, or a lateral condyle fracture? Let's go back to the image again here for you. Okay. We'll work on this. So, In a medial epicondyle avulsion, in this case, you can see that there is a fragmented appearance of an ossification center in the suspected area of the trochlea. So in this case, you can see intra-articular displacement of a avulsed medial epicondyle. And this is the pseudotrochlea ossification center. So a medial epicondyle avulsion looks like this. The important thing to note here is that you don't see the medial epicondyle. So if you're going through your list of CRI-TOE, you're missing it, and you have a T. So you should never have them in order when you're missing one. Supracondylar fracture is the most common elbow fracture in children. Again, you have effusions around the joint, elevating fat pads. You have your anterior and posterior fat pad, and that raises concern for intra-articular fracture. And you can see in this case that the fracture line is well seen, traversing all the way across the supracondylar region. In this case, there's no displacement. In our institution, they will cast these or pin them. If they're displaced, they definitely reduce them and pin them with cross-K-wire fixation. Monteggia fracture, just to review, fracture of the ulna with dislocation of the radial head. You can see this picture here where you have, where it's important to see orthogonal views to look at the radiocapitellar relations, because on the frontal view it doesn't look too bad, but on the lateral view you can see volar displacement of the radius. So make sure that you have orthogonal views at the elbow whenever you have a mid-shaft ulnar fracture. And our case was actually a lateral condyle fracture, and this is something that's frequently missed, because everybody remembers supracondylar fracture in children and usually remembers or can figure out the Monteggia fracture because it's not exactly around the elbow, involves a dislocation. But lateral condyle fracture is something that's frequently missed, and it can lead to significant morbidity as well. The trick here is that the oblique views are your best friend, because those are the ones that may demonstrate the fracture cleft the best. On the lateral view, it may look an awful lot like a supracondylar fracture. And here you can see a little bit of a lip. So the diagnosis here is lateral condyle fracture. So just remember, again, crital around the elbow, always do your order, and hopefully you'll be in good stead. I have lots of time, though, so I want to say thank you. And I don't know if any of you remember Dr. Zeus from ages ago, but I like Dr. Zeus. This is what I'm going home to. So quite happy to be returning to my family. But we have an extra case. So this one is one where it's a 17-year-old male, and he fell while playing rugby. It's an obvious clavicle fracture and tender AC joint. And we're always taught not to be satisfied with one thing, but to keep looking for something else. So in this case, again, obvious clavicle fracture, but there is an abnormality seen around the left scapula near the acromioclavicular joint. Again, here, more imaging, clearly pursuing this, thinking that there's something going on here. And transaxial view here, very nice. So, what's the correct diagnosis here? Is this an acute acromial fracture and accompanying with a clavicle fracture? Is this AC separation, deltoid avulsion, or ossicromiale? So please make your choice. Very good. Okay. So in this case, I'm not going to go through them all. I'm just going to talk a little bit about ossification around the scapula. So you have the preacromium, the mesoacromium, and the metaacromium. And again, around the shoulder joint, it's important to remember where things attach and when they fuse, because the age is really important in making a diagnosis of whether or not you have an open growth plate, or whether you've got a potential Salter 1 distraction injury, or whether you truly have a fracture in something that's already fused. The benefit is you often have an opposite side, but we try not to image opposite sides without warrant. So ossicromiale is the ossification centers about the scapula, they usually see consolidation of the bones, so joining of the bones and fusion across these growth plates between 17 and 18 years old. And they ossify medially towards the clavicular facet. The most common form of failure is fusion between the meso and metaacromium, and it's present in 8%, and interestingly, when you do have it, you have it bilaterally in 60%. It can be symptomatic in adults, and sometimes if it is symptomatic, can lead to issues with rotator cuff as well as impingement and so on. So just really important to know about osteochromiale. Again, thank you.
Thank you, Dr. Ayika. Thank you very much.